Welcome to the 2026 Valve Awareness Day for the Minneapolis Heart Institute Foundation. My name is Ross Garbrick. I've had the privilege of being with the foundation for almost 20 years now and currently serve as its Vice President of Scientific Services. So I'll walk you through just a brief schedule for today. But first, I'd like to take a moment to thank our grant funders and exhibitors in the back. All you do to make sure that we can have days like today, continue innovation and new novel treatment options for our patients are so greatly appreciated. So thanks for all you do. For everyone here, if you didn't have a chance, if you didn't have a chance to stop by their exhibit tables on the way in, please do so on the way out. They have a lot of the novel technologies and therapies that we'll talk about today. You get to feel them hands-on, ask different questions about them. So one of the rare instances where you get to be kind of up close and personal with devices that we are lucky enough to use every day in research. And so for our schedule for the day, I'll do the welcome here. We have a short patient story because everything we do at the foundation begins and ends with our patients that we so greatly appreciate in research. And then we've got a host of physicians who will give some great talks. So we have Dr. Jennifer Riggs, who will talk about valve disease in general. We have Dr. Sebastian Atura, who will talk about lifetime management, which is increasingly important as we have more options in this field. And then we have Nadir Ahmed, who will talk about life-saving therapies and how MHIF plugs into that. And then finally, we'll have a question and answer for all of you here, given this day is for you and for your education as well. So we have the Minneapolis Heart Institute Foundation. We've been around almost 45 years. We operate as the research and education arm for the Minneapolis Heart Institute at Allina Health. We have a pretty bold vision, creating a world without heart and vascular disease. That said, after today and after hearing from our three great speakers, I think you'll see the great innovations that we've seen in valve care in the last 15 years. And all of those things started with bold ideas and bold questions from our industry partners as well as our physician partners who conduct research. We also have a mission of to improve cardiovascular disease, or cardiovascular health of individuals and communities through research and education. So just to give you a little idea of what that looks like, we have about 220 to 250 studies at any one given time at the Minneapolis Heart Institute Foundation. About half of those are from our industry partners, so they're bringing new devices or drugs to market. We then, in turn, go out and find patients who might benefit from those new therapies. The other half are from our wonderful physicians, so they have questions that pop up throughout their clinical care days. A lot of it's focused on what I would call value-based care. So which device, what patient, when should they receive it, how should it be done? So it's a lot more of the operational pieces, almost like an optimization of medicine. And so that leads us to seeing nearly 3,000 patients each year for research visits. So very much so keeps us busy. In terms of the education that we do, we publish about 350 papers a year. So that's basically 9 out of every 10 days throughout the year. We have a novel research paper coming out in a journal that will disseminate the information that we know to physicians. We do another 300 abstracts and talks from our physicians throughout the year. So it equates to almost 2 events a day, basically, throughout the year where our physicians are out talking to patients, other clinicians, and just really disseminating the research that we do. In addition to that, we provide over 11,000 hours of general education throughout the year. So we have things like grand rounds where our physicians will show up and learn about what's the latest and greatest in individual areas. We also do on the pulses for community awareness. So they're about 60-minute videos or interactions with our physicians throughout the year that allow you to ask questions at the end of them, somewhat similar to this, but in a virtual space. And then lastly, we have our summer internship program. So that's almost 250 undergraduate students that have come through the program at this point, 85% of which are or are on the path to being practicing physicians. The remaining 15% end up somewhere in healthcare but may not be physicians. So we have pharmacists, physical therapists, or people like me who go into research instead of on the clinical side. So I just want to say thanks for all that you do. About half of our revenue at the foundation is from sponsored clinical trials and grants and different things that we write. The other half of the revenue is from grateful patients and philanthropic donors. So I just want to say to all of you who have donated to us throughout the years, We couldn't do it without you, and absolutely appreciate all that you do. And a good way to start the day, because we are patient-focused, is with a nice patient video of Marlene, who is continuing her valve journey throughout her healthcare space. And after that, we'll turn it over to our physicians.
It's called a brain exercise. Oh, I got one. My name is Marlene Knight. I'm 87 years old, and I have gone through the research team at Abbott to get a new heart valve, which was so successful for me. 13 grandchildren, 26 great-grandchildren. Now this fall in September, we've been married 70 years. Okay, I'll help with this. I just love to clean my house and cook and, bake. So I'm still the master in the kitchen, yeah. Several months ago, I was so tired. Still trying to work in the kitchen and making a meal. There were times I had to just leave and go lay down because I was so tired. I was so tired, I just couldn't keep going. The Lord is my rock, my fortress. I kept seeing Dr. Ash, and they kept doing the echograms on me. And his response to me is, well, you have heart failure and you have a valve that's very leaky. So we didn't do anything about that for a long time. But then my son, Bruce, said, Dr. Ash, my mom wants you to fix it. So that's when actually Dr. Ash then, he said, go to the research team. They'll do it for you. And that's when things really started with my trips to Abbott. So that I had to pass all these tests, which took a while, but I finally passed them. When Grant called me, my lovely Grant, I love him so much. Okay, we're scheduling you for November 10th. I knew they were going to go through the vein, and I had a picture of the valve, so I knew what it looked like. I just trusted them, and I trusted God in my life, who helped me through all this whole operation. When I came home, it was normal. Just go with how you feel. They didn't tell me I had to do anything. They did encourage me to go to rehab, however. I used my walker to walk at the high school. Am I going too fast? And I'll just keep walking. I guess that's really an important part of recovery. So I'm getting stronger. I think I did almost like a half a mile. It gets better every day. I don't think I even had a nap yesterday, so I'm hoping to maybe get one today. I've had follow-up appointments at Abbott. Yeah, I have a schedule kind of where they want to keep me in contact. Yeah, well, I have to go back first, make sure that valve is working. Yesterday was my first day to get into a car and drive myself to a friend, pick up lunch at Culver's. If someone came to me and said, Marlene, you have gone through this surgery to get a new valve, should I do it? I would tell them, you should do it. Try to get it fixed. It was the best experience I ever had, and I'm so thankful to the team for taking me on as one of their patients, for the thought even that I could live longer, to be with my family and my grandchildren and everything.
Whoa.
If I could talk to my care team, thank you for being so patient and kind with me, and the surgery to me went so well. To me it was perfect. It's my miracle.
Thank you very much. My name is Dr. Nadira Hamid. I'll be talking to you later. But really, this video of Marlene, and I'm part of the care team that looked after her, and I was also in the procedure in November when we did this procedure with her on this new valve. And truly it's such an honor, and we are privileged to have patients like Marlene and yourselves to trust us with what we do. And truly the new valve that she had, we are actually one of the few institutions in the country who have access to it. And so from myself and the entire team, we want to thank you and everyone here for your support to allow us to do what we do, to really broaden the therapies and the innovation in Minneapolis and Minnesota. So really, truly want to thank you from the bottom of my heart and from my entire team. And without further ado, to continue with the program, let me introduce to you one of my lovely colleagues and partner, Dr. Jennifer Riggs, who will be talking to you on the heart valve, just the awareness and the introduction. With that, Dr. Riggs.
Good morning, everyone. Thank you all for coming. So my name is Dr. Jennifer Riggs. I'm one of the interventional cardiologists here. So I'm kind of specialized in structural heart and valvular heart disease. And so I'm going to give you a quick overview of heart valve disease. All right, so what is heart valve disease? And so really it's any of several conditions that can cause problems with your heart valves. And so I always tell patients, I like to think of the heart as a house. And so in your house, you have 4 rooms, and those rooms are all connected by doors. And so you have 4 doors in your heart, and those doors are between each of these chambers or rooms, and they are, the doors are your heart valves. And so they are thin flaps of tissue called leaflets, and they open one way and seal tightly to prevent blood from flowing backwards or regurgitating and leaking. And so in the heart, as I mentioned, you have 4 valves. You have 2 atrioventricular valves, which connect the top chambers or the atria, and the bottom chambers or the ventricles. So on the right side of the heart, you have a tricuspid valve, and on the left side of the heart, you have a mitral valve. You also have 2 semilunar valves, and these are doors or valves that open from the heart to an exit point. So on the right side of the heart, that's a pulmonic valve between the right ventricle going to your lungs, and on the left side of the heart, it is the aortic valve going from the left ventricle to your aorta and out to the rest of your body. And so the heart beats 100,000 times per day in the average human, and it pumps 2,000 gallons of blood throughout the day. So if you think of that, that's 3,750 of those 2-liter bottles of soda that you can buy at the grocery store. So the heart is working really, really hard. And so those beats represent potential wear and tear to the heart. And so you can imagine if the valves aren't functioning well, it can result in reduced blood flow to the rest of your body. What are the types of valvular heart disease? So when we think of problems with heart valves, they really come in 2 different flavors. And so you can have stenosis or a stuck valve, or regurgitation or a leaky valve. And so in a stenotic valve, the leaflets become stiff and narrow so that the valve is not opening well, and this reduces blood flow to the rest of the body. So the heart often has to pump a lot harder to get blood out to the rest of the body. In a regurgitant or leaky valve, this is also called insufficiency. This happens when the leaflets don't close completely. This results in blood flowing in the wrong direction, and so your heart actually has to work a lot harder to make up for pumping that blood flow a second time to get where it needs to go. And so when you have heart valve disease, what are common symptoms? So I would say one of the most common symptoms is actually fatigue or decreased exercise tolerance. And so oftentimes these symptoms are really insidious, and patients will just say, hey, doc, I'm getting older. It's no big deal. But really, if you have a change in kind of your exercise tolerance or you're feeling more fatigued, it may be a result of a valvular heart issue. And so other common symptoms include symptoms of heart failure, like shortness of breath or swelling or edema in your lower extremities and in your abdomen. People can also have irregular heart rhythms, so you can get palpitations or extra heartbeats. In general, patients may feel weak and lightheaded, again, because you're not getting enough blood flow out to the rest of your body. And this may result in people syncopizing or fainting. And then in some patients, they also get angina or chest pain. So there are multiple causes of heart valve disease, and so probably one of the most common causes is, unfortunately, this is something that becomes more common as people get older. People can also have valve disease from congenital issues. So congenital heart disease makes up about 1% or people who are born, about 1% of people have congenital heart disease, and valvular heart disease makes up a portion of this. You can also get heart valve disease as a result of damage to the heart. So if you've had a prior heart attack or if you have heart failure, this can result in damage to the muscles and the structures that support the valves and cause them to become dysfunctional. You can have heart valve disease as a result of infections. And so the most common cause of valvular heart disease worldwide is actually as a result of rheumatic fever, which is very uncommon in the United States now. This is something that results from an untreated strep infection. And we've been treating patients in the United States with antibiotics for strep infections for the last 80 years. So this is not something we typically see in people who are born in the United States, but it is the most common cause of valve disease worldwide. You can also have valve issues because of endocarditis, which is a result of a bloodstream infection that then infects the valve. People who have had prior cancer with radiation therapy to the chest, this can also result in valve disease. The radiation itself can cause the valve leaflets to become damaged and stiff. You can have valve disease as a result of autoimmune and connective tissue diseases. So things like lupus and Marfan syndrome can result in valve disease. And then if you have an aortic aneurysm, this can also cause issues with the aortic valve, typically aortic regurgitation or a leaky aortic valve. So risk factors for heart disease are the typical risk factors that you would expect for most types of heart disease. So as I mentioned, older age makes it more likely that you'll have valvular heart disease. If you have a family history of heart disease, this oftentimes can make you more susceptible. If you have a personal history of heart disease, it increases your risk of valvular heart disease. Traditional risk factors for cardiovascular disease like high blood pressure, high cholesterol, obesity, and diabetes also increase your risk of valvular heart disease. Smoking as well, and then as we mentioned, if you have a history of congenital heart disease, history of rheumatic fever, autoimmune disease, or radiation treatment for cancer. So what is the prevalence of valvular heart disease? So in the United States, about 2.5% of Americans are affected with valvular heart disease. So that comes out to be anywhere from 12 to 15 million people. And unfortunately, valvular heart disease is responsible for 25,000 deaths annually in the United States. As we've mentioned already, the prevalence increases with age, and so 1 in 5 adults over the age of 75 have valvular heart disease. And so if you can see in the graphic on the left, as you get older, more likely or there's increased incidence of heart disease. So we're going to do a pop quiz right now. And so which of these conditions has worse survival? Untreated aortic stenosis, breast cancer, or prostate cancer? Shout it out. So the correct answer is severe untreated aortic stenosis. And so we know that when patients have symptoms from their severe aortic stenosis, the survival rate at 2 years is 50%. At 5 years, it's essentially universally fatal if it's left untreated. In contrast, the survival rate for most common cancers in the United States, if treated, is between 60 and 70%. For breast cancer specifically, the 5-year survival rate is about 90%. For prostate cancer, the survival rate is closer to 98%. And so we know that interventions for valvular heart disease, recognizing this, is very important to improve quality of life and also survival. And so if you got that answer wrong, you're not alone. 75% of Americans know very little about valvular heart disease, which is why it's very important for events like this. And so thank you all for coming. And so kind of leading into that, any idea how many patients get treated for their heart disease? So less than a third of patients. And part of this has to do with kind of underrecognition of valvular heart disease in the United States. And so we do have a range of treatment options. So starting on the left-hand side from conventional surgery with a sternotomy to minimally invasive surgical approaches, and also now new transcatheter therapies that we can do these procedures going in through either an artery or a vein, typically in the leg. And we have options with catheters now to treat all 4 valves, so the aortic, the mitral, the tricuspid, and the pulmonic valve. And so Dr. Arturo will talk a little bit more about this later. And so then this is just a quick video of a patient. And so this was a gentleman who we treated with a mitral clip for a leaky mitral valve, and this was him 3 months after his procedure. So we do have a range of treatment options that are minimally invasive that really allow people to get back to the quality of life that they want and to live the life that they want. And so in summary, valvular heart disease affects 1 in 5 adults over the age of 75. Unfortunately, women are less likely to be diagnosed and are often less likely to be treated. The prognosis is worse than many common cancers if left untreated. There are many treatment options available, and research continues to advance technology. So both Dr. Atur and Dr. Hamid will talk about these 2 points moving forward. And so what can you all do? So first of all, thank you again for coming, but keep learning as you're doing now and get the word out. So these are a couple of resources to look into. Thank you, guys.
Good morning, everyone. Thank you for coming. I'm Sebastian Atur. I'm part of the surgical team at Alina, and I work very close to Nadira. Dr. Riggs, she works in a United Hospital, but we're all part of the team, and we kind of focus on what the heart team means and why we try to do the best approach for every patient. So to try to simplify the lifetime management, we're only going to talk about the aortic valve, and we're only going to talk about aortic stenosis, this narrowing the valve. So normally the aortic valve is a very fine 3 little doors, 3 little leaflets, 3 little cusps that with time, with different situations, can get calcified. This calcification makes it more rigid, difficult to open, and then you have aortic stenosis, which should get treatment, as Dr. Risk was just mentioned before. Now, historically, this has been treated with surgery, open heart surgery. And why? Because we know that when you do open heart surgery, you get 2 main benefits: to live longer and to live better quality of life. So as of today, almost every patient that has aortic stenosis should be treated. And again, in the past, surgery was the only option. But we know that surgery is a big intervention. It's a big trauma to the patient, which means that there's a big time recovery, and hopefully after a few months, he can be fully back to normal. And over more than 60 years of cardiac surgery, there's been a lot of knowledge to how to make valves better. Initially, tissue valves, mechanical valves. There are a lot of different improvements to try to get the perfect valve, but as of today, we don't have that perfect valve because we have to start from the premise that if you have a valve, you can either have a mechanical or a tissue valve. If you have a tissue valve, it will never last forever. It will never be made as the ones we were born with. It will last a few years. It's always hard to predict how many years, and patients always ask me, how long will this valve last? I think it's an average. Some patients we know that last 2 years, some others 30. We tend to say this around 10 to 15, but it's a promise we cannot really promise because it's very independent for patient to patient. On the other hand, if you have a mechanical valve, we know that necessarily you have to be on blood thinners. You cannot have a mechanical valve without blood thinners, and there have been multiple studies, but they have to be Coumadin or warfarin, which is the old standard blood thinner medication. When they try to do Xarelto or Eliquis, which are the new medications, it didn't work. So if you have a mechanical valve, you have to have Coumadin as the only option treatment today. And we know that all of us try to avoid anticoagulation. Anticoagulation necessarily comes with potential complications. So again, we don't have a perfect valve to solve this problem as of today. We know that when you have a mechanical prosthesis, this anticoagulation, the longer years you are with it, the more possibilities have complications. Either it can be clots or bleeding, because that's what the medication is intended to do. And when we try to simplify it, and I'll try not to be too technical, I know there's some very heavy slides, but if you're young, it's more beneficial to have a mechanical valve because you're expected to live longer, and those valves are meant to be longer. When you get on the older spectrum of life, and I think old or young is a very relative subject, it's never defined what's young, what's old, but usually if you're younger than 65, you should probably be indicated a mechanical valve because you have better chance of doing well in the long term. As we say about surgery, and we'll try to simplify, we call SAVR, surgical aortic valve replacement. It was originally done with a full sternotomy. Sternum is the bone right here in the breastbone. Before, it used to cut all the way up and down. Today, when we do isolated aortic valve, we can do minimal invasive or partial sternotomy, which means basically open in half, which means a faster recovery. But I always tell the patients I don't want to be misleading them to say it's a surgery. Even though we open half of the bone, we go through the right chest, it means a surgical intervention. And this is a video. I'm sorry, this is a little blood. I'll try not to. I know people are eating here, but this is what surgery means. It's a lot of people. It's basically anesthesiologist, there's perfusion, and what it means is a heart-lung machine, which we're going to see, which is the only way we can do open heart surgery. It's a machine that can replace the function of the heart and lung while we have to do the intervention of the heart. And at the end of the case, that's the machine that you're seeing there. And at the end of the case, we need to start letting the heart beat again, and that's why we do surgery almost every day for valve disease in the OR. It's reproducible, has been done for decades, and we know it's safe, but it's still, as we say, it's a big intervention. Once we get in there with the aortic valve, it's very simple what we do. We take out a valve and put a new prosthesis in there. But to do that, we have to get all this full setup from the OR, which means a lot of support. Now, on the other hand, with technology, 2007 was when it started, 2010, 2011 was when it started becoming a reality, and 2014 was when it was been approved for a lot of patients. It means the transaortic valve replacement. And to try to summarize, we're going to call it TAVR, which means through the groin, you advance a sheath that it has a valve inside, and you deploy a valve inside your previous valves. You do not take the valve that you were born with, and that's kind of the big difference between SAVR, surgical, and TAVR through the catheters. And it's done usually in the cath lab, which again, is a big setup. It's a little more simplified than the surgical OR. You don't have a heart lung, you have the perfusionist, and most of the time it's even done awake. Here we have the two main valves that are available commercially today in the United States, but basically the principle is the same. Through the groin, you advance the catheter, you cross the valve, and once the valve is in there, you deploy a valve inside your previous valve. It's a very much more simplified procedure. Now, when you try to compare what's better, SAVR, again, surgery versus TAVR, there's a lot of things that need to be considered. First is the patient's preference. And I do surgery, I believe surgery is a good thing, but if it was up to me, I would try to avoid everything that I could to have open heart surgery. So it's, again, we premise that we have to start with the hopefully less invasive, faster recovery procedure. Age, as we said, is a very relative concept, but it is important to consider which one is best. If there's any medical risk, it's not the same if you're 40, for example, on dialysis, that if you're 80 and you're fully active. So it's not only age, it's other medical condition, and that it all relates to the risk of surgery. And another very important thing is the anatomy. TAVR is all a procedure that has to be done predictable, that you can have it done safely, and we'll talk a little about it next. But when we compare side to side, as we said, surgery includes an incision. The other one is basically through the groin through a puncture. One requires general anesthesia. Surgery, you have to have it done. Today, the TAVR, most of them are done with some sedation, like when people have a colonoscopy. You're just awake, but you're calmly restless, you're not agitated during the procedure. It requires a heart-lung machine, as we said, the surgery. Hospitalization is usually less than a week versus the TAVR. Some patients have been released the same day, usually stay overnight in most centers to have a TAVR done. And as we said, the surgery, just because we have to get through the bone, there has to be a recovery, which is like breaking an arm, I'll say an arm a month, maybe a little more. But with the TAVR, you go right away, and I know what Dr. Riggs showed for the mitral valve, but that's a reality. You can probably be very active after a few days. But as we said, the TAVR, it's all about predicting the chances of doing good. And that's all on pre-analysis with a CT and echocardiography. So there's a lot of imaging to make sure that you're a good candidate to have this TAVR procedure done. And we meet in the valve conference team, and that's one of our picture of what our conference team is. And there's a lot of people there. There's interventional cardiologists, the doctors who do the TAVR. There's surgical cardiothoracic surgeons, me, imaging specialists like Dr. Nadira. There's valve coordinators, research teams, heart failure specialists, and advanced practice providers. So it's a full team to evaluate the risk of going through one procedure versus the benefit of the other procedure. And what do we do in this meeting is basically see if you have a good, what's your valve condition, what's the overall age, but it's not only age, it's health. What's your lifestyle? If you're willing to take blood thinners, if you need a mechanical valve, what are the plans for the future? And obviously, the patient has a lot to say. You all have a lot to say. What's your personal preference? Now, to try to simplify this, we base our strategy in guidelines. And usually, when we say age, if you're young, younger than 65, our patients tend to do much better with surgery than a TAVR. On the other side, if you're older than 80, patients tend to do much better with TAVR than surgery. And in between, there's a big gap that can go both ways, and that's where this big heart team analysis comes into place. Now, I know this is a slide when they try to compare surgery with TAVR, but the truth is that multiple studies have shown that TAVR is good, and TAVR has done a very good job, and the results for long terms are well. And that's why more and more patients, if you see that kind of orange line going up, numbers of TAVRs have increased significantly with time, and the light blue line, the numbers of surgeries have gone down. And it makes a lot of reasoning for what we all know about how good the results of TAVR are. But the other important thing is that when we compare age groups, when patients less than 65, as we said, they should go to surgery because the results of surgery are better, they're still getting a lot of those patients TAVR. And that's it's a little hard. This is the overall statistic in the United States, but it also relates to how much benefit the heart team decides to what's better for the patients. Because we know when we compare surgery with TAVR in younger patients, surgery is a better fit for that specific population. And the answer is a little technical, but as we said, our aortic valve usually has 3 doors or 3 cuffs. When you're younger, you have aortic stenosis, it tends to be a bicuspid valve, which is something that you start hearing around when you have these medical problems. And the bicuspid valves are valves that are very calcified, they're asymmetrical, so TAVR tends not to be a very good fit, and that is all can be predicted with all the CT analysis. And again, if you're not good at fit, that was when surgery probably makes a better sense for these patients. And again, we have to go back to the basis of these principles when you have tissue valves. When we do open heart surgery, we can put a mechanical or a tissue valve. When you do a TAVR, they're all tissue valves, so we're going to be faced that those valves are not going to last forever. And the younger we have those valves, the more likely that valve is going to fail with age, with time. So what to do when the valve fails? If you have a surgical aortic valve, a tissue valve that fails, you can undergo a redo surgery, which it's a big deal. You already went once. Going back in there is even bigger yet. It's a little riskier yet to go in there. Or you can just get a TAVR inside your surgical valve, what we call a valve-in valve. When you have a TAVR that failed, you can either take that TAVR out surgically, or you can have a new TAVR inside the previous TAVR, which is called TAV-in-TAV. Now, there's a lot of studies that show that obviously if you compare redo surgery versus putting a valve-in valve, if you do a redo surgery, it's going to be a longer time in the hospital, more risk of bleeding, longer recovery. So that's why a valve-in valve becomes very meaningful as a procedure. But you have to think that every time we do this, we're going to be consuming more of the space inside the valve. It's kind of the Russian doll effect, that if you start putting too many things to have less space to actually make blood go through, which you need that opening so the heart can pump all the blood out. This is another example of the valve, a TAV-in-TAV. So you had a TAVR, that TAVR failed, and you can actually put a new TAVR inside a TAVR, which seems very simple as a procedure. But again, you have the same effect of putting too many things inside, and you also have to make sure that the arteries of the flow, the arteries of the heart that give flow to the heart that are very close to the valve, don't get obstructed with the procedure. And I know this is another busy slide, but what it means is that after this, we know that so many patients are getting TAVRs. That means that a lot of patients with TAVRs could be failing. And as a surgical community, we've been getting exposed to more surgical TAVR explants, meaning that we have to take the TAVR out because they're getting younger patients and probably should not be the right thing to do. Now, I know this all comes to this big slide, which is the heart team again decision, to provide what's best according to how young you are, how good in health you are. Again, the younger you are, you should probably go for surgery. The older you get, probably TAVR seems a good option, but there's a huge gap in between that where the valve team becomes very important to consider what's the best option for you all. So to finalize it and summarize it all is that the treatment of SAVR versus TAVR and the lifetime management is a multifactorial between age, cardiac and valve anatomy, surgical risk, but we always try to favor the less invasive approach. And there's always between this balance for life expectancy, the risk of the procedure, and hopefully, but you know it will happen, the future reintervention, and it's a personalized multidisciplinary approach to get the best solution for each specific patient. Thank you.
Thank you so much, everyone. Thank you, Jennifer and Sebastian. Before I move to my talk, if you have, there's a lot of information, please write down their cards on the table and write the questions, because right after my talk, the 3 of us will be able to answer all your questions. Hopefully we get through all of them, or we will be also here after the sessions as well to answer all your questions, okay? And so what I am, my name is Dr. Nadira Hamid. What I am, besides my interventionist, Dr. Riggs, and my surgeons, I'm the imager. So I am their eyes to the procedure. That's how I label myself. When I tell my patients, I'm the eyes to the procedure. So I'm the imaging expert with my team. We look at all these imaging from echocardiography to CT and really diagnosing the valve disease. And so my talk today is going to be about life-saving research, the work that all of us do with my team, a huge team, and I'm going to show you in these slides It's not a one-man show. It's a huge entire team, as what Ross has illustrated, to be able to do all those publications. And so here, the mission of the Heart Valve Center at the Minneapolis Heart Foundation, really we want to improve lives of all of you who have valve disease, whether is it severe, that we need intervention. Now we are seeing a lot of patients, even moderate leaky valves or stenotic valves, that we need to follow them up because we want to be able to intervene them early, as studies have shown recently. And so we want to do this not only just to treat the patient, we want to be active in research and innovation so that all the technologies, not only in the United States, but the world, is available to all of us here in Minnesota and also in the United States. And so you heard from Jennifer Riggs, the interventionist. So she's the interventional echocardiographer right here. You heard from Dr. Itura, who is the cardiothoracic surgeon. And I fall into this category where I specialize in advanced cardiac imaging. So not only just the basic imaging, but I went extra years to really learn about valvular heart disease and understand it and really diagnose it well. And so Ross in the first has introduced us. We do a lot, we present a lot each year with all of these publications. We also have an app by Dr. Vinny Bapat, who is a world-renowned surgeon and is award-winning. And people actually use this app all around the world. And it's actually grown here in Minneapolis Heart Institute Foundation. I'm so proud of it. We have educational courses. Despite our busy schedule, we do actually do courses and teach to other physicians, not only in the United States, but also in the world as well. And we have one coming up in May. I myself am also doing an imaging workshop as well to teach and really help spread the awareness of what we do here. And also the opportunities to do the first numerous cases of first in human here in Minneapolis. And so really, really fortunate to have all these technologies here. And all this publication that we do is, by us physicians, but truly is by all these clinical research scholars that come from all over the world to our foundation. Look at the, oh, did I move forward? Here. Yeah, right here, sorry. So you can see so many every year that people from all over the world, these scholars apply to us. Ross can attest to that. And we are so fortunate. They come from Japan, they come from Europe, and also in the United States as well, to come here to Minneapolis and to help us physicians really understand. We have weekly meetings every Wednesday morning. We sit with them, we go through their ideas and what the data analysis, and we put this information out there. We publish them in top-tier journals in the entire world. So really kudos to them who work with us so closely. And with that research, it has impacted how we practice valvular heart disease. On the left-hand side, is actually one of my colleagues, Dr. Joel Cavalcante, who can't make it. He's also an advanced advanced CT imager actually. And there he is with our previous Japanese scholar and presenting here at last year, the biggest conference, cardiology conference in the world, the European Society of Cardiology. It was held in Madrid last year, where they updated the guidelines of how we treat valvular heart disease. And our work was actually published in the big screen right there. It's really amazing and truly a proud moment for all of us and the entire team in the foundation. And on the right-hand side here is actually one of the other trial, the Triluminate trial, which is the first trial for the tricuspid regurgitation. That is the forgotten valve, but now we can't stop talking about it because it's so rampant around and it was undertreated. And now we have new technologies, and this trial, we were the highest enroller. We did so well in the trial, and we actually worked with FDA and Abbott Company to really help put it out into the market. That is available now commercially for all patients. So really, truly, the work that we do in the foundation has impacted with the regulatory processes and also on the world stage. So truly, thank you so much for all your contributions. And without the innovation, the new technology, like Marlene's story that you saw the video, that is a new mitral valve that we are in part of the trial. But these are all the cases that we have done over the years, as you can see, all the first cases that the industry has supported us to do great work, to put these valves out, not only in clinical research, but also in the market. So really, we are fortunate to be able to do all these new technologies and being able to be the first in the country and in the world to be doing all these new technologies in Minneapolis Heart. As you can see, the top row, the three of us are here, but it's not just the three of us, it's a team of physicians. And the bottom row, I just want to highlight, this is Dr. Vinny Bapad, our cardiothoracic surgeon, Dr. Joao Cavalcante, our imaging expert as well, Dr. Vudras, and Dr. Mario Gessel. All of us work hand in hand and are key opinion leaders in each and every one of our field. And really, it's truly a team together with everybody, the rest of the team in Minneapolis Heart Foundation, to bring this technology forward. And so the trials, as you have heard from Dr. Itura and Dr. Riggs, that we are actually exposed to, you can see the number of trials of the aortic trial, the mitral valve, the tricuspid, and the pulmonary. So so many trials that we are involved in. And we truly cannot do all these trials without the team by Lisa and Nikki, who's over there as well, with a couple of members and coordinators here. These are a couple of pictures that, this is the, sorry, just going to go back, our valve party that we had and a trip that they had. Really, these trials are handled by Nikki and Lisa and the entire team to make sure that each of these patients follow up. You saw Marlene's story, that there's a lot of tests, there's a lot of follow-up, so we truly appreciate your patience, but really it's so methodical to ensure that these trials are done methodically and absolutely on spot so that we get the good outcomes. Now, without further ado, I'm also heavily involved as well in, we know there's a lot of sex differences between men and women, not only in other diseases, but also in valvular heart disease. So the Minneapolis Heart Foundation is also active looking at these gender differences within our population and community in Minnesota and Minneapolis as well, because we want to understand what are the differences between men and women. We know that in all the diseases, and even the heart disease and valvular heart disease, that women present late. We do present because we women tend to hide our symptoms a lot more. And when we present them, when women present to the hospital, they are really very sick. And so we are raising the awareness in Minneapolis Heart Foundation with regards to women and valvular heart disease. Gretchen and her team as well, I'm working very closely with them to really look at the data and analyze these patients very well. And we have seen that not only they present later, their symptoms are worse, and also their outcomes, if they present later, is also worse than men as well. And so we will be presenting this data at some time this year, but really our foundation has worked aggressively to look at the differences of men and women as well. Now the question is, all of you sitting there might be thinking, why is research important? Not only to us physicians in the foundation, but also to yourself, right? Because I think the access to novel therapies, you heard from Dr. Itura that we have commercial devices that's available for everyone, but the heart is very different for each and every one of you. It's just different. When I look at all the images, my heart is different from Sebastian, my heart is different from Ross, and each of you are different. And so the accessibility to different devices, I think, is crucial because it provides the variety of options. And when we discuss cases in the valve meeting, as what Dr. Itura showed you the picture, we look at everything, all the images from echocardiogram and CT, and look at the different anatomy, and we are so privileged to be able to have a variety of options for the patient. And so I think it's important, research for yourself, because we have the access to all these therapies. We do have our team to be active as well in personal care of all of you. And also really for you, the last two pictures, you can see that, really for yourself, the quality of life, and like Marlene having 26 great grandchildren, that's amazing. We want you to have that quality of life with your children, your grandchildren, and live as long as possible. That quality of life, that's really what we want for all of you. And really the last picture here from the recent novel device for the aortic regurgitation, all the care that we have as a team that is knowledgeable, and together with our research team as well, that I feel really motivated. I actually went to the hospital before I came here, and I saw one of our patients that we did a tricuspid valve replacement just on Thursday. Eric from Edwards is here, and this morning I was going to discharge her home, and she told me she has never been so happy, and she cried on me, and I told her, this is what we do. This makes me happy and motivated for what I do every single day and the passion that I do. And I could also say the same for Dr. Riggs and Dr. Itura and the rest of the foundation as well. And so really, I think research is important. And, talk to your primary care, talk to your cardiologist, primary cardiologist, and come to us. You have access to us by email, by phone, and we, the clinical team there, will also be able to look at your eligibility for different trials, whether it's a commercial or is it a trial. We'll get your consent, obviously, to be able to look at your data. And based on what you have and what we have, and we'll do the recommendations and the options, what is best for you. Your primary cardiologist and us will work very closely together, and we'll give you the feedback. And once you have the procedure, it doesn't stop there. Once you have the procedure, it doesn't stop there. Don't think we'll just leave you alone. You will still continue follow up with us aggressively, whether it's a commercial device or a research device, and we'll take care of you, okay? And so really talk to your doctor to understand all your options. We have a website, the Minneapolis Heart Foundation website, and also have a section on the valve. And we are here as well to contact. So if you have any questions, do write them down, and we'll be answering right after this. And just would like to thank you for coming. And with that, thank you very much. All right. I just saw the first card, and I absolutely love this question already. And I think it's going to be for Dr. Itura. The question is, are we researching to see if a failed TAVR can be taken out, replaced with a new one, or instead of dropping just another one inside of the failed TAVR?
Okay, so taking out the TAVR means open heart surgery. And you have to think the patient went for a TAVR before for maybe a specific reason. He didn't want or she didn't want surgery for the first start, maybe it was a high-risk surgery patient. So taking out a TAVR means you're probably older than, obviously you're older than the first intervention, so it means a higher risk yet. And that's why I think with the newer technology, putting a TAVR inside a TAVR seems very reasonable. But the truth is that we still don't know how long will this new TAVR last. I mean, we don't even know how long the first TAVR lasts. So there's a lot of uncertainty. And yes, there's a lot of interest in the medical community to try to figure out what's better, taking out the TAVR with a more risk or putting a new TAV in TAV. And I think that will be answered in the future. But as of today, since we don't have the specific answer, that's why I think it's so important to not be only a one-person decision. For example, if you go to a surgeon, they'll probably say do surgery. If you go to a TAVR, go to a TAVR. And that's why we rely on this valve committee, which I didn't specify, but it's a lot of surgeons, a lot of interventional cardiologists, a lot of imaging doctors that try to get the best decision as a group. Hopefully that will be the best decision for this specific patient.
Can, to that point, maybe, Dr. Riggs and Itura, we really look at patients, right, to see whether should we remove the failed TAVR valve or should we put another one, right? Any thoughts on that?
Yeah, so I actually a month ago, I had two different patients who both had failed TAVR valves. And so one of them was in her mid-80s. And so she ended up going for a repeat TAVR inside her old TAVR because she was not a great surgical candidate. The other one, unfortunately, well, not unfortunately, but she is going back within the next week to have her TAVR valve removed, and we'll have a new surgical valve. And her circumstances were very different. She was a little bit younger, and so the reason she got a TAVR initially at a younger age than we normally would have typically done is she was a primary caretaker, unfortunately, for her husband who had pancreatic cancer and passed away. And so in that stage in her life, it didn't make sense for her to go through a major surgery with, as Dr. Arturo mentioned, 2 to 3 months of recovery time, as she wouldn't be able to take care of him. And so I think both are options. Sometimes people can't get a repeat TAVR, and so surgery is the only option. And that's where, Dr. Hamid and our imaging specialists come in and help us a lot because sometimes, as Dr. Arturo said, it's like those Russian nesting dolls. There's not enough room to put another valve inside in a minimally invasive way.
And
Sorry,
yeah.
can I add? So Nadira's presentation, when she said all the clinical trials that Abbott and MHI has been involved with, one is specifically done for that kind of question. That means RESTORE trial, which is see how well do patients do when you have a TAVR inside a TAVR, a TAV and TAV. So it's a multi-center with multiple locations across the United States. We're part of them, and it's to try to figure that answer because again, the answer is not there yet, and I think the best way to do is all this research that we've been talking about to give the best option for each specific patient.
And Sebastian, I'm sure you must be, one question that came to my head, which I'm sure some of you, is the removing the TAVR a huge surgery, right? Because, you went in through the groin first, right? And now you have to take out, the entire thing, right? So perhaps just for everyone.
So this is something new for surgeons because TAVR hasn't been that long. And as everything something new, there's a period that people have to learn about access, complications, and how to treat those complications. So the answer at the beginning, yes, it's considered a high-risk procedure. But as people get more experience and more exposed to these cases, the results have been getting better too, meaning that it's not an ideal situation, but right now we have the technology and the knowledge to make it as safe as we can.
No, absolutely. And I think the community now are thinking much more now during our discussion in the valve meeting, as to what size. And we think about, okay, this valve in the next 5-10 years, what's going to happen? The discussion now is more in-depth thinking to Dr. Ituro's point of lifetime management, right? What is the next option? What is the next kind of backup plan, right? Dr. Ituro and Dr. Riggs, would you say that?
Yeah, and so I think, most of the patients that I meet in clinic, they all come to me and they want the minimally invasive approach. And I think that's great, and I would love to do that, but I'll be the first to tell you if it's not the right thing for you. And obviously, we very strongly take into account your opinion and what you want done. But in some people, like yesterday in clinic, I met a 45-year-old who wanted me to do a TAVR. As Dr. Arturo mentioned, not a great option. So TAVR valves are all tissue valves, and so on average, we expect them to last 10 to 15 years. So she's looking at multiple interventions in her lifetime, and so this is where the lifetime management strategy is very, very important. And then obviously, it's our job to educate you as to why we are making these recommendations.
Great. And the next question: do you think the guidelines for cardiac surgery to look at intracardiac symptoms, are they, have the guidelines for valve surgery looking at intracardiac symptoms which are related to valve disease? Yeah, Dr. Riggs.
Sorry, so
The question is more of have the guidelines of heart surgery.
So for heart surgery, so the general cardiology valvular disease guidelines, it's usually a combination of multiple societies, so cardiac surgeons, cardiologists, interventional cardiologists, heart failure specialists. The most recent guidelines were published in 2020. And so there are multiple committees that work on these all the time, and usually it's every 10 to 15 years there's an update. And so the most recent guidelines, there were several changes 6 years ago. The biggest being that in 2019 is when the FDA approved TAVR for anyone over the age of 65 in the United States. And so that was incorporated in the new guidelines. But prior to that, it was kind of a class 2 recommendation. And so yes, they're constantly being revised with the research that that we're doing here and that is being done elsewhere. But sometimes the societies are a little bit slow to put out that information.
And what we, the imaging community, have also worked on is numerous papers that came out. Besides the aortic valve disease, we have now also looked at the rest of the chambers of the heart. Because imagine like what Dr. Riggs have shown, your heart is like a house. You have the doors and the chambers are connected, right? And so if your valve is is stenotic or blocked, the back pressure that goes into your left ventricle, to your lungs, and also to your right ventricle, it's all affected. So the longer you continue with this narrowing of your aortic valve, it does affect the rest of the chambers of your heart. And so we, the imaging community, have realized that, acknowledged it, and the structural community have also developed a classification as well by one of my colleagues in New York. And really we have understand better now on valvular heart disease of aortic valve, mitral valve, and tricuspid valve, and understand the physiology of it. And really the consensus of all of us is really to identify these patients early through imaging, obviously, and try to intervene them early before the symptoms. So a lot of the research trials that we are doing now around the country and the world is on why wait till severe, but why not we do the intervention earlier on, moderate, before the changes of your heart gets damaged. So we, the community, working with a lot of centers in the country and the world, looking into that, and through further research trials, both by Edwards and Medtronic on the moderate aortic stenosis. So the data hopefully will be out this year or next year. And so we look forward to that and really understand this disease better. And we want to intervene earlier before the symptoms and before the complications of the disease itself. And so much more to come is what I say. Yes.
Yeah, to add to that, because I think that Nadira is making a very good point. And it's all the guidelines, obviously, they're a little outdated because people have to get together and space information. As Nadira was saying, the European guidelines was just updated last year. The American guidelines are still a little behind, so there should be a coming up soon. But it's true that we today do surgery or TAVR intervention when you have symptoms, and probably we're getting late. When we have symptoms, there's already been some structural damage to the heart to have symptoms. But it's all related to a balance between risk and benefits. We know, because at one point surgery was much more riskier than today, and we know now with the interventional cardiologist intervention that the risk is not even that high anymore. So if you wait that long, you're probably not doing a big benefit for the patient. So there will be a point, I'll believe strongly, that we'll be much more aggressive in treating disease earlier, so you don't have to be experiencing symptoms and at one point saying that you're so advanced in a disease that there's little chance of regression of that disease.
Thank you. And the next question, after mitral valve repair, do you still need to take antibiotics for dental?
Yes, you do. So either, regardless of how the valve is repaired or replaced, either with a catheter or surgically, unfortunately, bacteria in the mouth love to go to things that we put in the heart. And so after any valvular heart procedure, you are on antibiotics that you will take even before routine dental cleaning, an hour before you get your teeth cleaned for the rest of your life, to minimize the risk of endocarditis, which typically the only way to treat that if it becomes an issue is antibiotics and then surgery to remove the valve.
And the next question to that was, how often do we do echocardiogram after mitral valve surgery or repair or even an intervention? That's a great question. I know the guidelines, they mention it longer, like 3 years or so. But for my practice, I don't know about the two of you, I tend to do echocardiogram once a year because really to make sure that, because the durability of the valve still is there, because every 3 years, it's too long, I feel. And so my practice for all my patients is once a year, echocardiogram. And just to have a visit with me once a year just to make sure everything's okay. How about you, Jennifer? And
I agree. And so if I'm doing a mitral valve repair, so a mitral clip or a Pascal device, I will get an echo the following morning. I'll get one at the 1 month mark and then every year after that. I think some of our surgical colleagues don't do it as frequently as we do, but I think if the patients are being followed by a cardiologist, which most of them have, they will get an echocardiogram annually as well.
I think it should be once a year
Yeah.
for any kind of valve intervention.
Agree. I know it's out of the guidelines, but the guidelines is just kind of an idea of the practice, but I think it's best once a year for sure. The next question is actually very interesting. It's, the TAVR procedure and coronary stents, right? Maybe Jennifer, does it reduce the frequency to the question of getting another coronary stent procedures going forward and the challenges probably?
Yeah. And so the initial TAVR valves did not take into account the orientation of the location of the coronary arteries relative to the aortic valve. And so the initial early patients who got TAVRs as part of the clinical trials, it was very hard to get back in if someone was having a heart attack after their TAVR, days, months, years later, to get back into their coronary arteries. And so as someone who in the middle of the night comes in to help people who are having heart attacks and open up their arteries, when you heard initially, a couple of years ago that someone had a TAVR, you always, what valve did you have? Because it made a difference if I can go on your wrist or if I have to go into your groin. And so now both Medtronic and Edwards, who make the FDA-approved valves that are used currently in the United States for TAVR, both of the valves take into account the location of the coronary arteries, and when we're planning on how to deploy the valve, we take that into account. So it's a lot easier now to re-access or get back into the coronary arteries. It is a little bit more challenging than if you were not to have a TAVR valve, but it certainly can be done.
Yep, and the new reiterations and how we align the valve, all these technical aspects of putting in the valve, right, Jennifer? I think we have learned so much that if they need to go in to put a stent, it's not an issue, because we have learned so much in the early years of TAVR that how to arrange the valve so that for easy access, all of these technologies and the learnings that we have in the early days have been applied. And so putting in a stent after the TAVR procedure shouldn't be an issue. Yeah. Next, 2 questions, but the first one is, why is it less diagnosed for women? Maybe Dr. Riggs. Yes.
So I think Dr. Ahmed kind of alluded to this as well, but I do think women, or at least the patients that I personally met, tend to minimize their symptoms. I think it's also true that women, they do present later, but part of it is, I do think, women, life expectancy in the United States is longer than men, as it is kind of worldwide. And so they tend to be older when they have symptoms and when they develop disease. And so for that reason, your primary care doctor, your general cardiologist may say, hey, you're 85, there's probably not really any options for you. And so, until you are made aware by other people or doing your own research that there are options for you, we tend to present later. And so I think that's a huge part of it. And so raising awareness that there are options. So I always tell patients the oldest patient I've done a procedure in is 101 years old. And so he had severe aortic stenosis. He did really, really well. And so for me, age doesn't faze me. And so I think, there are options. And if you have true valvular heart disease or cardiac issues, we can treat you.
I couldn't agree more. Age is just a number. I've met, since I moved from New York, I've met so many Minnesotans who have lived their life 80, 90s, all the way from here to Cambridge, where I do my clinic, and they look amazing for their age. And I tell them, I say, you look like you're 60 or 70 years old. I mean, absolutely. And so, why age is just a number. So when we discuss these cases in the valve meeting, right, Dr. Turner and Dr. Riggs, we assess, how, we look at you even from surgical standpoint, right? in terms of how fit you are, in terms of, remain active is what I say. Doesn't mean that you have a valve disease or after a valve disease, you can't remain active. Go for your walks, go for, exercise daily, because that will keep you healthy and really fit for whatever future intervention that needs to come. And the valve disease should not affect your lifestyle. And we are here to help improve your quality of life and spend time with your loved ones. Last question to each of you. Someone asked, do we work in various hospitals? So maybe just for your practice?
Yep, so I'm one of the interventional cardiologists. I am primarily based at United in St. Paul. I also have a clinic in Woodbury, but I do all of my procedures right now at United Hospital.
Yeah, I work at Abbott Northwestern, which is the big heart hospital. I have to cover United Hospital, and from March we need to start working at Mercy Hospital too. And we have outreach at different centers. I have to go to Baxter once a month.
So as you know, I'm the imager, so I'm also a general cardiologist as well. And so my practice is mainly in Abbott Hospital, so I do my clinics there as well. My other clinics that I practice in is an Edina clinic and also all the way to Cambridge as well. Yeah, so feel free to contact us or any questions, let us know.
Good.
Perfect. If there's no further questions, just want to check around, Robin. There any other questions, or you want to put up your hand and ask us? Please feel free. Yes, sir. Yes, hold on. The mic, please. Yeah.
It's on. It's on.
Going to play in the decisions that the valve committee makes in the future regarding data?
Oh, that's a great question.
I think we're speculating. I could tell you my opinion. I mean, at least from surgical point of view, I think we have worked for many years yet until AI kind of replaces us. But I know from the AI in the analysis, a lot of the imaging, CTs, that's a lot of the measurement of the size of the heart, of the annulus, the coronaries, a lot of things that are technical that before someone had to measure it, now it's done by a computer system. Will that be completely replace the meeting? I doubt it will happen because there's a lot of, as we said, age is a number which the computer can definitely define, but it can never tell you how fit, how strong you are. I think there's a lot of appreciation. I mean, there's scores to tell how frail you are, but frailty, again, is a very subjective concept, which no computer can tell you that today. So I think, at least from the human contact point of view, I think there's still a lot of work for us to do in this AI current world.
From my world, huge. I would say, I think the impact of AI, I think, can be very beneficial. I think that we have seen it, especially in imaging, especially before diagnosing the patients with valvular heart disease or any heart disease. AI has played a huge role in detection, and I think from imaging, even in cardiac CT or echocardiogram as well, the incorporation. How so? For example, like say the aortic stenosis, to Dr. Itura's point, the use of software platforms that utilizes artificial intelligence in trying to simulate the valve into your aortic valve, into your VAR. We can simulate all of these valves that Dr. Itura has shown with all the reiterations into a heart model of yours based on your CT or your echocardiogram. This is before the procedure. We also have AI advances in the procedure room as well with the technology of echocardiogram, which is my area of specialty, where they fuse AI with the fluoroscopy and echocardiogram to guide the procedures for Jennifer and Dr. Itura to place the valves. So there's a lot of advances in that technology as well. So really, I think AI is a useful tool. And if it's to replace us, I don't think so. Otherwise, I'll be out of a job. But I think it's a great adjunct. And using it well together with our knowledge And our experience, I think, is such a powerful tool and to give you the best outcomes and success, you know what I mean? And I think that really helps us a lot, I think, using it together. Jennifer, any thoughts about that?
No, I think I agree with you, Dr. Hamid. So where I've seen it used is integrating in the cath lab or during our procedures with imaging, and then also to plan procedures. And so I trained at the Cleveland Clinic, and so we did a lot of 3D printing and made models of hearts to simulate how we were going to implant valves. And that's more common now today, and especially when we're doing some of these research or trial cases, and if we're doing a procedure for the first or second time.
No, because it was so funny. That question is great because I did a webinar on echocardiogram for the tricuspid valve and how to use with 3D eyes on Thursday. That is broadcast to both Europe and US. And one of the innovation on the third talk by one of my colleagues from Europe was talking about exactly that, AI incorporation with the fluoroscopy, where we are able to guide the device, the clip, or the replacement technology much easier. And we will be getting it soon in Abbott. So I'm really excited about it because it helps accuracy, precision, and efficiency. That's why you don't want to be in a case for 2-3 hours, or 4 hours. And so the use of AI together with what we have right now, and we work very closely with vendors, Philips, Siemens, and GE, all of these ultrasound companies, because we want to make this procedure, streamline this procedure, make it easier, make it accessible to not only high volume centers in Minneapolis, but all around the world, so that all patients can get access to it. So that's our ultimate goal. And so AI with what we do really helps. Thank you for the great question. Any other questions? Yes, ma'am.
Coronary arteries, whether it's your valves, preemptively before you're symptomatic. Can we do that these days, or do you have to be symptomatic to be finally diagnosed and treated?
That's a great question. 1,000%, yes. I see a lot of patients in my clinics anyway, maybe, that these patients come to me and said, there was one patient of mine, I was treating her sister, and she just had a family history of narrowing of her blood vessels around her heart, very young, her entire family, like really strong family history, and she just wanted to be sure that everything was okay. And I did a scan on her and came back so positive that she needed a bypass surgery. Yeah. And so I saw her, she got the scan on that morning, I called her, came to emergency, and she got the surgery by one of Dr. Ituro's colleagues within 2 days in Abbott. And on that Saturday where I was doing a clinic in Edina, her sister came and see me. and she said, yeah, you're treating my sister and she's now in Abbott. Oh, I said, okay, and I remember. And so to that point, I'm a huge advocate for patients, all of you, your family, if you're worried about something, yes, to come and see us, because it's always good to have a heart check to know the status of your heart and be able to know what to do next, basically. So yes, to me. How about Jen and Sebastian?
I think you do not need to be symptomatic to have a referral to a tertiary center. I mean, if you have a valve disease that is significant, one of the things it needs a very close follow-up. A follow-up is clinically, echocardiographically, other advanced imaging, but we definitely try to reach or diagnose it before we become to a point which is too reversible or have further complications. So your answer is yes, it needs to be referred before that.
Yes, depending on the test and your insurance, but we'll work with you and your insurance to see what you need and what is available. Absolutely.
And what Indira said before, we're getting to a point because of safety, or how safe the procedures are, that we may be able to do procedures before it becomes symptomatic.
Yeah, no, I think just to add to that, I would say probably the most common reason people come to me or that I see patients with valve disease who are asymptomatic is their primary care doctor heard a murmur. So they'll get referred to a cardiologist, we'll get an echocardiogram, and you may not have symptoms at all, but maybe you have a mild leak or a mild narrowing that then will continue to follow.
With that, I think we've come to a conclusion. Thank you, Jennifer and Sebastian, for your talks, and thank you everyone for coming for Heart Valve Awareness event. Thank you.